Assalamu alaikum dear students. I am Dr. Ambreen and I am your course instructor for the course of Pharmacology and Therapeutics 2. In today's lecture, we are going to study about anti-protozoal drugs and we will be also discussing about anti-malarial drugs. The first part of this video is related to anti-protozoal drugs and the remaining part of this video is related to anti-malarial drugs. Let me tell you the learning objective of today's lectures include after the end of this session, you will be able to understand that what are anti-protozoal drugs and what is the chemotherapy of amoebiasis and how it is going to be transmitted in human beings. And you will be able to explain the pharmacological management of this amoebiasis. And in the coming session, we are going to discuss about anti-malaria drugs in which we are going to study about the life cycle of malaria and going to discuss about the possible drugs that are going to be used in malaria. Let's revise the last lecture. In the previous lecture, we had actually studied about clarithromycin, zithromycin, azithromycin, telithromycin, and we have studied about their effectiveness and also studied about the antibacterial spectrum. We said they are effective against many of the same organisms as like penicillin G, and many be used in the patients who are allergic to penicillins as well. Moving towards the protozoal infections, I want to tell you about this a little that it is one of the most common condition that is present among people. Protozoal infections are actually common in underdeveloped tropical and subtropical countries where sanitary conditions, hygienic practices are not good, where the control of the vector of transmission are inadequate. Previously, they were actually confined to specific geographical conditions, but nowadays it has increased due to the increased world tour. Because these eukaryotes, the unicellular protozoal cells, have metabolic processes that are closer to human cells as compared to prokaryotic bacterial pathogens. These protozoal diseases are less easily treated with the bacterial than with the bacterial infections. I am going to repeat this, that these protozoal diseases are less easily treated as compared to the bacterial infection that we have studied about different antibiotics and different bacteria. And many of the anti-protozoal drugs can also cause serious toxic effects in the host, particularly in the cells showing high metabolic activity like different cells of neuronal, tubular tubules, tubular cells, renal cells, and intestinal cells, in the bone marrow stem cells. They are even not considered even for safe for the pregnant women. So let me tell you something more about protozoal infection. That these are actually being transmitted by the contaminated food and by the contaminated water that we are going to take. Actually, the water is the main source of amoebiasis. This is going to be transmitted to us through the feces of the infected person, and we are going to use that water, and then it is going to transfer to us. Moving towards the chemotherapy of amoebiasis, it is also said to be amoebic dysentery. It's actually infection of the intestinal tract that is caused by Entamoeba histolytica. There are different types of the amoebiasis depending upon the severity level. We categorize it either acute, either chronic. The symptoms are also going to depend either they're mild, moderate, or severe. So might be possible a lot of people are asymptomatic, but they are said to be potential carriers of these amoebiasis. However, there would be no symptom. Asymptomatic means no symptom in a person. But even those persons who are asymptomatic, who doesn't have any symptom of amoebiasis, they are actually said to be the potential carrier that can be actually able to transmit these diseases. The diagnosis is established by isolating the Entamoeba histolytica from the fresh feces. And this is the diagnostic criteria that we are going to diagnose it. Acute amoebiasis. I said there are two levels of amoebiasis, acute, chronic. Fine. So acute amoebiasis can contain signs and symptoms like bloody mucous stool. It do also have abdominal pain. Patients usually feel abdominal pain. This is a symptom that is also present in the chronic like amoebiasis, along with anorexia, intermittent diarrhea, constipation. Patient sometimes feels intermittent like situations like due to some GI irritation, intestinal motility has increased due to abdominal pain, so there would be diarrhea. But if there is slowing of movement of the intestinal tract, it may even cause constipation. So now I'm moving towards the life cycle of Ant-amoeba histolytica. This is very important to understand that what is the life cycle of Ant-amoeba histolytica, so that we would be clear that how this amoeba is going to transfer to us and how we are going to survive with it, how we are going to be the host of Ant-amoeba histolytica, and what are the types and what are the ways it is going to affect our human body, and what are the possible effects, and how we are then be the carriers to transfer it to the other human beings. Like as you can see in this picture, that the person is going to ingest the amoeba. There are two types of the amoeba that are actually present. It is present in the cyst form, it is present in the active form. The cyst form is ingested by the person and it is through the contaminated food and water. Like you can see here, I'm going to just show you the marker. Right. So this is the first step. This one is the first step, that is ingestion of this cyst into the human body, and the person is going to ingest it. And what is going to happen, this cyst is going to travel through the esophagus, through the mouth, and then it is going to move towards the GIT tract, and ultimately it is going to come in the intestinal tract. And you can see in this picture the yellow one are the cyst, and that actually contain the like amoeba inside it. So there would be the formation of trophocytes that are in the next phase of this cyst, and this cyst is going to open up and it is going to give you trophocytes. Like here you can see this is going to happen is there would be the formation of the trophocytes that are going to be released in the intestinal lumen, and these light blue colored or like sky colors are the trophocytes, like you can see. So number one is the ingestion of this amoeba in the form of the cyst. This cyst is going to form the trophocytes, and these trophocytes are going to be come into the lumen, and what are they going to do is either they are going to infect the luminal area, either they are going to invade the intestinal wall. This pink colored is the wall, and these trophocytes are going to invade the intestinal wall, and from here they are actually infecting the wall and going to stay in the intestinal wall, and they are going to invade this area. And what they are going to do is after that they are going to cross this barrier and going to move towards the liver. And in this way you can say it is going to spread in the body. We will say they are going to give us systemic effects. I am going to repeat all these things. We said that the cyst is going to travel ingested through the feces, and we are going to ingest it through the contaminated food and water. It is going to pass into a lumen of the intestine where the trophocytes are liberated, and these trophocytes are going to multiply. They either invade or ulcerate the mucosa of the large intestine and simply feed in the intestinal wall. These trophocytes within the intestine slowly are carried through the rectum, where they turn to the cyst and going to be excreted out. I said this is after some of them are going to infect the intestinal wall. Some are going to infect the lumen of the intestinal wall. Some of them are going to be go out of this way, and they are going to give us systemic effect. And the trophocytes within the intestinal wall, like you can see, those are in the intestinal wall, are slowly carried out towards the rectum, and towards the rectum they are going to be excreted out, and this is the way they are going to be again discarded by our body, and they are going to come in our feces, and these would be the next potential carriers for this one. Fine. So here comes the number of the steps on which we are going to work. Either we are going to work over this bacteria or trophocytes that are going to infect the intestinal lumen. We are going to induce or use such drugs that are going to act over the area where there is the trophocytes in the intestinal wall. We are going to work over the third thing, that is over the systemic trophocytes. So let me tell you about the classification of the amoebicidal drugs. According to the site where the drug is effective, we have classified it into luminal, we have classified it into systemic, we have classified it into mixed drugs. Before that, the one that are going to act on the lumen as well as over the systemic effects. The next is the drugs that are going to come under this category, and they include idoquinolone, deloxynate furan, paramycin, tetracycline. They are the drugs that are going to act on the parasite in the lumen of the body. The next we have is systemic amebicides, mean that are going to act extraintestinal, and these are the one that are effective against the amoebas in the intestinal wall and in the liver. Mean other than the lumen, they are going to act in the intestine or over the systemic or over the liver all the way. It is out of the lumen. So chloroquine and is a systemic amebicide. It is also an anti-malarial. We are going to study about chloroquine in the malaria as well. The third one is mixed amebicides. They are the drugs that are going to, and these mixed amebicides include metronidazole and tinidazole. We are going to study about these metronidazoles in detail. Metronidazole is one of the drugs that is actually the named as flagellant, we commonly use in our homes or in daily lives, or whenever we get any like dysentery, we come to use and flagellant. I'm going to revise the mixed amebicide. I said they are the drugs that are effective against both luminal and systemic forms of the disease. So metronidazole and tinidazole are mixed amebicide. Metronidazole is named as flagellant and it is being commonly used in our daily lives. The next, we are going to discuss all these drugs one by one, and we are going to discuss about the mechanism of action. We are going to discuss about their side effects and uses. So let's start from the mixed amebicide, in which we studied about metronidazole and tinidazole. I'm going to start from the metronidazole, meaning the drugs that is going to have a nitromidazole in the structure, and they are said to be mixed amebicides, and they are being used for the treatment of amoebic infections, like they are going to kill Entamoeba histolytica trophocytes. Here I want to tell you that other than this Entamoeba histolytica, this metronidazole is going to be used in Giardia labelli, Trichomonas vaginalis, anaerobic cocci, anaerobic gram-negative bacilli, for example, bacteroides, Pseudomonas colitis. It is being used for all these type of bacteria other than Entamoeba histolytica protozoa. Fine. So this is a list in which it is being used. These are the list of the bacteria or infections in which we are going to prefer metronidazole or flagyl as a drug of choice. And Pseudomonas colitis is considered to be a priority drug, mean drug of choice considerably for the treatment of Pseudomonas colitis. The next we have is the mechanism of action of metronidazole. Mean how this metronidazole is going to work. Mean what is actually the rationale, what is the reason, and why it is being preferred for the infections of protozoas. So here this diagram you can see, and this one is the chemical structure of the metronidazole. Fine. And what this metronidazole is going to do is this metronidazole is going to go in the protozoa. It is going to convert in its metabolite that is, like you can see, with the help of an ferridoxin. Ferridoxin is going to be oxidized and it is going to convert this metronidazole into its metabolite, and this metronidazole metabolite is going to cause the defragmentation of the DNA. It is going to cause the fragmentation of the DNA. I mean, it is going to cause its fragments, and as a result, it would be difficult for the protozoa to survive. I'm going to revise. I said some of the anaerobic protozoal parasites poses ferridoxin, and metronidazole convert into cytotoxic compounds that find to be like proteins and DNA. And ultimately, it is going to cause the death of this protozoa. Ultimately, it is going to cause the death of the protozoa. The next is the pharmacokinetic profile. That how this drug is going to behave, mean how our body is going to behave with this drug. Pharmacokinetics is always the study what our body is going to do with the drug. Our body actually absorbs the drug, distributes the drug, metabolizes the drug, and excretes the drug. So now we are going to discuss about these features, that what is the pharmacokinetic profile of the metronidazole. It is completely and rapidly being absorbed via oral administration. Although there are a number of the factors that are going to affect its survival, we are going to discuss also. Along with this, it is going to accumulate in the patient with the severe hepatic diseases. The drug crosses the blood-brain barrier as well, and the drug and glucuronide metabolites are going to appear in the urine. I told you that this drug have interaction with the other drugs. What are they? If there would be another drug that is phenobarbital that is considered to be enzyme inducer is going to be given with the metronidazole, it is going to enhance the rate of the metabolism of metronidazole. While if the metronidazole is going to be taken with the cimetidine and ranitidine, famotidine, they are H2 receptor blocker, it prolongs the plasma half-life. So it means it has a drug interaction. If we are going to take them with the inducers, they are going to enhance the rate of metabolism. And if we are going to take with them with the inhibitors, they are going to prolong the plasma half-life. Fine. So these are the actually drug interactions of the metronidazoles with phenobarbital and cimetidine. The next are the adverse effects. Mean what are the possible side effects that we can encounter when we are going to use it? It do causes gastrointestinal upset along with some unpleasant or metallic taste, which is very common with the use of metronidazole. Yeast infection in the mouth. Really, some neurological problems like dizziness, vertigo, numbness, and paresthesia is also seen. If taken with alcohol, it is going to give you disulfiram-like action that is often seen in the patients of the alcohol who are going to take alcohol. So this is a picture just to revise some of the common effects of the flagell, mean metronidazole, that the patient usually experience headache, patient feel dizzy or lightheadedness, along with diarrhea and stomach pain or cramps, and also do faces nausea and vomiting and loss of appetite and nausea. Fine. Now we are going to discuss about the resistance. It is not actually a therapeutic problem that we are going to face by these protozoas towards the flagell. Although the strains of the Trichomonas vaginalis, they are going to act over the vagina, they are going to show some resistance to this drug. Now we are moving towards the last part of this metronidazole that actually includes the uses of the metronidazole. That along with the meiosis, where it is going to be used. It is going to be used in the meiosis we said. It is also being used in giardiasis. It is being used in Trichomonas vaginitis, and it is being preferred in anaerobic infection. So let me tell you what is giardiasis. Giardiasis is Giardiasis is microscopic parasitic infection that causes the diarrheal illness. It is actually giardiasis is a bacteria that is actually found on the surface and soils of like damp spaces, and that are going to contaminate the feces, and that is this soil is actually contaminated by feces. I'm going to revise what is this giardiasis lambuli. This giardiasis is due to I'm going to revise what is this giardiasis. Giardiasis is actually a diarrheal disease that is caused by the parasite Giardia. And in this condition, the patient feels fatigue, nausea, diarrhea, appetite, vomiting, bleeding with weight loss and excessive gas. And this is the one parasite that is found in the surface of the soil and water that is contaminated by the feces. Fine. While the next is Trichomonas vaginitis. Trichomonas vaginitis is a sexually transmitted disease caused by the Trichomonas vaginalis. The next we have in anaerobic infections, it is being preferred. Along with this, it is being used in pseudomonas colitis, Helicobacter pylori infections, acute ulcerative gingivitis, itis is inflammation of the gingiva or the buccal cavity, dranculosis. The next, what is dranculosis? Dranculosis is also named as Guinea worm disease, a parasitic infection by the Guinea worm. A person becomes infected when they drink the water that contains the water fleas infected with the Guinea larva. Moving towards the next is tenidazole. This is also another mixed amiboside. It's the second generation nitronidazole. It is similar to metronidazole and it is being approved by USA Food and Drug Administration in 2004. Its spectrum of activity, its absorption, its adverse effects, and drug interaction has been proven by this FDA. Uses for the treatment are in which these drugs are being used in amoebiasis, amoebic liver diseases, giardiasis, trichomonas vaginitis. It is as effective as metronidazole and short course of treatment are required, yet it is more expensive as compared to the generic metronidazole. The next we have is luminal amibicides. Usually after completing the treatment of extra-intestinal amoebic diseases, a luminal agent should always be administered for the treatment of the asymptomatic colonization state. Idoquinol is a luminal agent. It is an amoebicidal that is going to act against Entamoeba histolytica. It is effective against the luminal trophocytes and cyst forms, mean for both the trophocytes and for the cyst form. Long-term use of this drug is avoided because it has a number of side effects like rash, diarrhea, those little peripheral neuropathy. Really do causes optic neuritis. The next is paramomycin. It is an aminoglycoside antibiotic. It is effective against Entamoeba histolytica, tear form diseases. It is actually not significantly being absorbed from the GIT. Like it is going to give us gastrointestinal effects like diarrhea, distress, and these are actually the principal adverse effects. GIT distress and diarrhea. The third category is systemic amoebicides, mean that are going to act over the amoebocytes that are prevailing or invading the systemic areas. It is useful to treating the liver diseases and intestinal wall infection caused by Entamoeba histolytica. In this come is chloroquine, that is also anti-malaria. We are going to discuss this chloroquine in detail in the next part of the video. It is also used in combination with the metronidazole. Here it is being preferred along with the metronidazole and diloxinate fuel to treat and prevent the amoebic liver diseases. It eliminates the trophocytes in the liver abscesses, but it is not useful in treating the luminal amoebiasis. Chloroquine is as effective or also considered to be effective in the treatment of malaria, and this is the first thing that comes in our mind whenever the name of the chloroquine comes. Moving towards the closing points of this lecture. In this lecture, we have studied different types of the amoebiasis, and we named the different drugs that are going to be used in amoebiasis for its treatment. And in case if the amoebiasis is asymptomatic or the cyst carriers, then we are going to use idoquinolone or paramycin. The next is in case of diarrhea or dysentery, extra-intestinal issues, we are going to prefer metronidazole plus idoquinolone or paramycin. In case of amoebic liver diseases, we prefer to use chloroquine, metronidazole, and diloxinate fuel. So this was all about Entamoeba histolytica. And in this, we have studied how it is going to travel, what is the life cycle of Entamoeba histolytica, and what are the forms that it is going to be present. I said it is present in the cyst form, it is present in the trophocytes. When it is out of the body, it is in the form of the cyst. When it is in the body, it is going to multiply, that it would be trophocytes. With this, I'm going to close up this part of the video in which we have studied the anti-amoeboid drugs. After this, we are going to continue with the next topic, that is anti-malaria drugs. I'm going to post up this video in the Google Classroom. Kindly go through that video and let me know if you have any queries in our next interactive session, or email me at ambreen.iqbal@usc.edu.pk. Thank you. Assalamu alaikum. I am Dr. Ambreen and I am your course instructor for the course Pharmacology and Therapeutics 2. In this lecture, we are going to discuss about what are anti-malaria drugs. This is the part 2 of the video that I have already posted, in which we have studied about anti-protozao drugs. And after the end of this session, you will be able to clear that what is malaria and how it is going to infect the human body. For this, we have to revise the life cycle of the malaria. So let me tell you that what is going to happen inside our body. And the learning objective of today's session actually included that after the end of this session, you will be clear about the life cycle of the malaria, and you can easily describe how your pharmacological management is going to stop the malarial multiplication and how you are going to control the symptoms. And in the previous part of this video, you have studied about anti-protozoal drugs, and in which we have studied about the protozoa in detail and how it is going to infect and what are the signs and symptoms and what is the management of amoebiosis. Now, I'm going to also tell you about the types that we have studied about the anti-amoeboid drugs, that there are some luminal amoebicides, systemic amoebicides, mixed amoebicides, and the flagell is one of the common amoebicides that we have studied. Now, jumping towards today's lecture that is actually related to malaria, I want to show you a video that is related to the malaria that is going to tell you how this malaria is going to be transferred in the human body and what is the way that it is going to proceed next week. So let's see the video that I'm going to show you. So here is the life cycle of the malaria that completes in two phases in human host and in the mosquito. It is going to suck the blood. See what is going to happen inside. That is going to travel then. It is going to actually multiply. They are going to travel. So in this video, you have seen about the first phase of the life cycle of the malaria that was in the human body. Now we are going to see another video that is related to the other half of the life cycle of the malaria. So this is the second half of the life cycle of malaria. So this was about the life cycle of the malaria and how the Anopheles mosquito is going to infect the human being and going to infect the one that is not actually was the carrier. Let's continue today's lecture that was anti-malarial drugs. Malaria is one of the acute infectious disease that is caused by the four species of the protozoa genus Plasmodium, Plasmodium falciparum, Plasmodium vivax, Plasmodium malaria, and Plasmodium ovale. Parasite is actually transmitted to the humans, as we have seen in the last video, through the bite of the Anopheles mosquito, which thrives in humid and swamp areas. Coming towards the first type of the Plasmodium, that is Plasmodium falciparum. It is one of the dangerous species that is being used going to be used and going to cause an acute, rapidly fulminating disease. And this may lead to the capillary obstruction and death if treatment is not instituted properly. Let's discuss the symptoms that we are going to face in the patient, or we are going to see in the patient of the malaria. Malaria is usually characterized with persistent high fever, shaking chills, massive erythrocytosis. Erythrocytosis is the abnormal elevation in the number of the RBCs converted by the swollen radish lymph. This is a picture to show you the signs and symptoms that are going to be seen in the malaria, that the patient is going to experience headache, fever, muscle fatigue, pain, chill, sweating, dry cough, spleen enlargement, stomach, nausea, and vomiting. So let's discuss about the life cycle of the malaria. In this life cycle, we'll be discussing how it is going to travel into the human body. Actually, the infected mosquito is going to bite the human tissues and going to transfer the plasmodium sporocytes into the bloodstream. From the bloodstream, they are going towards the liver, and in the liver, they are going to multiply and going to form merocytes. And these thousands of the merocytes are going to invade the red blood cells and become tropocytes. So after becoming tropocytes, they uses the hemoglobin as nutrient, and these tropocytes multiply and become merocytes. In fact, the cell ruptures at the last steps and releases the hemoglobin and release merocytes invade other erythrocytic cells, and few of the merocytes convert into the gametocytes, and these gametocytes are then again going to be entered into the mosquito that is going to bite that person. Fine, like in this picture, you can see these are the sporocytes. They are going towards the liver. In the liver, they are going to convert into merocytes. These merocytes are going to invade the RBCs and convert into tropocytes. These tropocytes are going to use the hemoglobin of the red blood cells and going to again multiply, and they are going to release thousands of the copies of the merocytes. And these merocytes then again going to infect the human body and affect the other RBCs. And few of these merocytes are going to convert into gametocytes, and these gametocytes are going to be going again into the mosquito that is going to bite the human body. The next is all about the life cycle of the malaria that we have studied how they are going to act. This is another picture that is going to show you the whole process in further detail. This picture is also added just to show you and again going to revise the life cycle of the malaria, in which we said the mosquito is going to bite and it is going to infect sporocytes into the human body through the blood towards the liver, where they are again going to multiply, and after multiplication these merocytes are going to be released, and these merocytes are going to infect the red blood cells, and in the red blood cells they are going to use the hemoglobin and they are going to convert. As soon as they are going to enter, they convert into tropocytes, and after using the hemoglobin, they are again going to be the merocytes, and these merocytes are going to be released and going to infect more RBCs and going to even convert towards the gametocytes and going to again enter into the another mosquito that is going to be bite. Here there is a word is schizontocytes. Schizontocytes are the cells that are invaded by these merocytes. Fine. Schizontocytes are the cells that has been invaded by the or actually these cells are RBCs, or they are been invaded by the merocytes. Then we call that cell schizontocytes. The infected blood cell is said to be schizontocytes. Now moving towards the classification that we can be going to discuss under the category of anti-malaria drugs. It contains 4 types: casual prophylactics, blood schizontocytes, tissue schizontocytes, and gametocidal drugs. We are going to discuss one by one each drug and what are the drugs under that category and what the casual prophylactics and all these are going to do. Casual prophylactics are primary tissue schizontocytes. They destroy the parasitic forms in the livers and prevent the invasion of the erythrocytes. So they are going to occur, they are going to work over the liver cells and going to prevent the multiplication, and they are also going to prevent the invasion of the RBC. Fine. Primaquine and primethamines are casual prophylactics. The next we have are the blood schizontocytes. These drugs that are actually chloroquine, quinaline, mefloquine, halofantrine, and trimethamine, they are suppressive prophylactics. They suppress the erythrocytic phases and prophylactically prevent the malarial fever as well. Fine. So this is the way they are going to act. And number three is tissue schizendocytes. They act on the hepatic forms of Plasmodium vivax and Eval, and they are given with the blood schizendocytes to cause the radical cure of this malaria and want to prevent the relapse of the malaria. Prima queen is a tissue schizendocyte. And next one, that is the fourth one category, is gametocidal drugs. They are going to destroy the gametocytes and prevents the transmission. And primaquine, chloroquine, quinine, they're all gametocidal. So primaquine is being considered in other classes. Chloroquine is also present in the other class. They are going to perform more than one action. So moving towards the chloroquine, and I'm going to discuss about this chloroquine in detail, that what it is going to do in the patient who has malaria and who is going to be infected by the Plasmodium malaria or Plasmodium falciparum. So moving towards the mechanism of action. Its mechanism of action is very interesting. Actually, the parasites digest the host cell's hemoglobin to obtain the its products or its amino acids. So what is going to happen, that this parasite is going to digest the host cell's immunoglobulin to obtain energy and by amino acids. This is the hemoglobin that the parasite is going to use its amino acid. After using the amino acid, the other end product is heme. And what the parasite do is, actually heme is dangerous for the parasite. So these parasites immediately convert this heme into another compound, hemosine. Hemosine is not actually dangerous for this parasite. So what these malarial parasites are going to do is, after using the hemoglobin's amino acid, they are going to convert the heme into hemosine in order to prevent the toxic effects of the heme. Hemosine is non-toxic, so these parasites are going to survive. But our drug, which is chloroquine, it is going to prevent the conversion of heme into hemosine. So when there would be high level of heme, that is toxic for the bacteria or for the parasite. So in this way, the survival of the parasite would be difficult. I'm going to repeat, our chloroquine is going to inhibit the conversion of heme into hemosine. In the parasite, the conversion is actually necessary because heme is toxic. So the parasite convert heme into hemosine for its own protection. But we want to kill this parasite, so we prevent the conversion of the heme into hemosine. The next is again about mechanism of action, that what is it is going to do, how it is going to bring about the pharmacological action. It is highly effective against the erythrocytic forms of the vivax, ovale, malaria, and sensitive strains of the falciparum and gametocytes of the vivax. It is not being effective in the resistant strains and not active against tissue schizendocytes. Something other about chloroquine is it is also effective as extraintestinal amoebiasis and giardiasis. It is being preferred along with malaria. It is actually anti-inflammatory. It has antihistaminic properties. It is going to act as a relaxant. It is going to affect the myocardium. So it depresses the myocardium. So these are some other effects of the chloroquine along with anti-malarial drugs. Moving towards the pharmacokinetic profile. It is well absorbed. It has 60% plasma protein bonding capability. It tends to concentrate in the liver, spleen, kidneys, and leukocytes. It has a selective accumulation in the retina, so it is going to give us an side effect, that is ocular toxicity. It has a half-life of 3 to 10 days. The next are adverse effects of the chloroquine. Chloroquine causes nausea, vomiting, skin rashes, headache, insomnia, sleeplessness, pruritus. Along with this, it causes visual disturbances, irreversible retinopathy. High doses causes cardiomyopathy and psychiatric disorders. Then this is the last thing about the chloroquine, that is the uses of the chloroquine. Malaria, that is high against the malaria, it is highly effective, and these chloroquine is going to deal with all the forms of the malaria: Plasmodium malaria, Plasmodium vivax, falciparum, ovale, and all these 4 types. Extraintestinal amoebiasis, it is being used in rheumatoid arthritis, photogenic reactions, and in leprosy as well. The next is something about quinine. It also destroys the erythrocytic forms of the parasite and is useful as suppressive. It is also being used as gametocidal, but except Plasmodium falciparum. It is not effective for Plasmodium falciparum. These are the you can say the effects of the quinine, that it acts as a mild analgesic. It has an antipyretic activity. It is a myocardial antidepressant. So we have studied already in the last semester under the heading of anti-arrhythmic drugs, quinine. This was the first drug that was actually introduced in the market as anti-arrhythmic drug. It's a local anesthetic. It has a skeletal muscle relaxant properties. So these are the adverse effects. Mean the adverse effects are actually side effects that we are going to get along with the pharmacological action. It acts as a gastric irritant. It gives us nausea, vomiting, gastric pain, skin rashes, and other effects like nausea, visual disturbance, and vertigo is also common with these effects. Quinine. It also causes hypoglycemia, fever, delirium, and CNS-related side effects. And then next are the uses of the quinine. Quinine is preferred in the treatment of the resistant falciparum malaria. It is being used in cerebral malaria and nocturnal muscle cramps, as it do act as muscle relaxants. The next we have is mefloquinine. It is another member of this class that is used as single dose usually for suppressing and curing the infection caused by multi-drug resistant forms of Plasmodium falciparum. And this is a chart that is going to summarize the effects of the anti-malarial drugs that all the Plasmodium species except chloroquine-resistant Plasmodium falciparum, chloroquine is effective for that. For the chloroquine-resistant Plasmodium falciparum, quinine plus pyrimethamine and sulfadoxine or doxycycline or clindamycin is actually effective. For the prevention of the relapse of the Plasmodium vivax and Plasmodium evale, only primaquine is effective. And this is these two like charts are actually such summary that in which type of malaria, which type of the drug is effective. For the prevention of the malaria, we usually use chloroquine sensitive, especially in the chloroquine sensitive geographical areas, we prefer to use chloroquine. And chloroquine resistant geographical areas, we use mefloquine. And in pregnancy, chloroquine and mefloquine both can be used. So this was all about the malaria. If you have any queries related to the anti-malarial drugs or related to the anti-protozoal drugs, kindly let me know in the next interactive session. You can also post your queries under the video that I'm going to post in the Google Classroom. And you can even email your queries at my email, that is ambreen.iqbal@usa.edu.pk. Thank you. I'll see you in the next interactive session.